Good morning, dear students. So today we will continue our first lecture. We need to finish it because it's very important to know the type of the bite. So on our previous lecture, we talked about the orthognathic bite. Today we'll continue from the direct bite. So direct bite differs from orthognathic in that the cutting edges of the upper teeth, they do not overlap but fall directly like forceps on the cutting edge on the lower teeth. So as you could see, the upper teeth, they do not overlap the lower teeth. So there is no overbite. We call this overbite. The overbite, this is 0 millimeters. In the area of the lateral teeth, the relationship between the teeth is the same as in orthognathic bite. As a result, in the presence of a direct bite, sometimes faster wear of teeth occurs than in the case of orthognathic one. Under such conditions, the surfaces of the teeth they are polished. The latter are resistant to caries, are firmly held in the cells, and are affected by periodontitis or periodontitis less often than in other forms of physiological bite. So this is the direct bite. So the next is the prognathia. Prognathia is characterized by a protruding position of the upper jaw. So as you could see on this picture, the upper jaw is protruded as a result of the distal shift of the lower jaw. It could be not only the distal shift of the lower jaw, it could be also as a result. There are three types. It could be as a result of the forward shift of the upper jaw is the first. The second, it could be as a result of the distal shift of the lower jaw. And the third is a combination when the upper jaw, the maxilla, has a forward position and the mandible has a lower or distal position. So there are three types of this prognathia. In the case of prognathism, the teeth of the upper jaw are pushed forward, and there is a gap between them and the lower teeth. So you can see there is a gap. Often the lower teeth touch the mucous membrane, damaging it during closing the jaws. In the presence of prognathism, a violation of the proportions in the area of the molar teeth leads to the fact that the anterobuccal tubercle of the first upper of the molar falls on the tubercles of the same name on the lower molar, and sometimes in the closing gap between the premolar and the buccal tubercle of the first lower molar. Later we'll talk about this classification. It's called the ankle classification. So all that we talked before, you could see in this picture. This is the position of the first upper molar and first lower molar. In the case of pronounced prognathia, the teeth of the upper jaw very much protrude forward, pushing out the upper lip from under which the cutting edge of the teeth are visible. So we understand that if the frontal teeth are protruded, the upper lip also must be protruded. So the next is the progeny. In the case of progenic ratio of the dentition, the lower jaw is pushed forward. If we talk about the ankle classification, it is called the class 3. So the lower jaw is pushed forward, as a result of which the lower front teeth overlap the upper ones of the same name. So we can see in this picture that the frontal lower teeth overlap upper frontal teeth. If the lower jaw protrudes slightly, contact is maintained between the front teeth. Food is bitten off with the front teeth in the case of similar jaw relationships. There are two types. If we talk about the progeny of this pathology, there are two big types. It could be the pathology functional. and it could be a skeletal pathology. If we work with our patient with which have a skeletal progeny, for example, a kid at the age of 9 or 10 years after orthodontic treatment, if we will protrude the maxilla forward and we make a good relationship between molars and canines, if the patient, if our child has a skeletal pathology, we could have a relapse. If it is a functional pathology, the prognosis of our treatment is good. So there are two big types of this pathology of this progeny: the functional and the skeletal. So, since there is a medial shift of the lower jaw, the anterior buccal tubercle of the upper first molar comes into contact with the posterior buccal tubercle of the lower molar of the same name or enters the closing gap between the first and second molars. You can see on this in the lower right corner. Deep bite. It is characterized by significant overlap, as we could see that we don't see the lower teeth of the mandible, so we could see only the upper frontal teeth. It's called deep bite. There is a significant overlap. The cutting edges of the lower teeth, they can touch the neck of the upper teeth in this dot. Sometimes there is no contact and the teeth touch the gums. The lower teeth touch the gums of the upper jaw, damaging them. Lateral incisors are closed as conditions of orthodontic bite. In the presence of deep bite overlap, anatomic variant of orthodontic bite, the upper front teeth overlap the lower ones by more than 1/3 of the height of their crowns, but the incisal bump contact is preserved. In the case of a deep bite, it is absent. Open bite. There is no closing in the front teeth. And sometimes the premolars, only the molars come into contact. At the same time, there are deep functional disorders. There are also two types of this open bite. So for example, we could have the first type and the second type of this open bite. For example, this is our second molars. And in the first type, of the open bite, we could see that the disocclusion becomes at the area of first or second premolars. There is the first type. And the second bite, the disocclusion, for example, it could be in the area of the second premolars or become even in the area of the third of the canines. This is called the second type of the open bite. Easier to work with the second type of the open bite because the first type often requires to extract the first or second premolars to close this bite. The lack of contact between the front teeth causes of the patient bite of food with premolars or molars. So in the molars, the first type in the premolars, it's second type. Reduction of the useful chewing surface, occlusion field, also makes it difficult to chew food. The tongue, which increases in size, takes a significant part in grinding food. If the tongue is really increases in size, we could see diastema, trema, so we could see spaces between frontal teeth. If the tongue increased in size. If the tongue is normal in size, there would not be there would be a contact between all these teeth. There would not be spaces. So if we see spaces, we need to think that there might be that the tongue is increased in its size. So if we don't need have a relapse after our treatment, we talked about the orthodontic treatment, maybe we need to make a surgical procedure to make the size of this tongue smaller. And only after that, there would be no or even less percent of a relapse of our treatment. Okay, think about the patient's language is impaired as well as his appearance. If we talk about this space between the frontal upper teeth and the frontal lower teeth, if this space, there are two types also. They might be this form and this form. If we see the patient's bite and and this space have this oval form, we could think that there is a problem with tongue. It could be a tongue sucking. For example, if a child, and we see that this page has this form, the first what about we need to think that this patient could have a problem with tongue sucking. If we could see that this space have a form of the semi-oval, there could be, for example, a thumb sucking. So if the patient has a thumb sucking, there would be this form. If the tongue sucking, this form. So this you could use in the clinic working with your patients. Crossbite. A crossbite is understood as such a ratio of teeth rows for which the buccal tubercles of the lower II.2 teeth are located to the outside. To the outside from the upper ones of the same name. The front teeth close correctly. You need to understand that there could be a cross bite and scissor bite. There is a difference between this. If we could see on this picture, this patient have a cross bite. The difference between the cross bite and the scissors bite. So, for example, this is maxilla, this is mandibular, this is maxilla, and this is mandibular. So this is upper teeth, upper molars, and the lower molars. So if we could see this ratio, we talk that this is a crossbite. And if we see this ratio, then the upper molar contacts only in one dot with lower molar, we talk that this is a scissor bite. It is different to work with scissor bite. It is more easily to work with cross bite. So there is a cross bite, there is a scissor bite. You need to understand these differences. As we could see, there is a narrowing of the upper dental arch. Narrowing of the dental arch. As you understand that, for example, the dental arch, this is maxilla, this is mandibular. There is a normal. And if we talk about the cross bite, or scissors bite, in one side it has a normal ratio between upper arch, dental arch, and mandibular dental arch, and on the other side the upper dental arch is narrowed. It could be as a skeletal problem, or it could be the reason that the patient, for example, it has a bad habit to sit, for example, this. And if the patient is really sit a lot of hours during the day, it could constrict the upper jaw on one side, and we will have a crossbite. So we could put this call a functional crossbite. A skeletal crossbite, if the patient don't have these bad habits during the birth, it has an error, so there is a skeletal crossbite. As you understand, it is better to work with functional crossbite. It is easily to treat. Okay, and now we'll talk about the classification. So there is the Dr. Engel. It is a founder of the orthodontic. Edward Engel proposed a classification based on the mesiodistal ratio of the tooth rows depending on the location of the first pair of permanent molars. Engel called the ratio of the first permanent molars of the upper and lower jaws the key of occlusion, believing that the first permanent molar on the upper jaw is a stable point. These pictures, as you can see, is from his original book of this Dr. Angle. So every dentist and every orthodontist know this Dr. Angle, as he made a great contribution to orthodontic and dentistry. With the correct ratio of the first permanent molars, the front buccal tubercle of the upper first molar falls into the front groove between the buccal tubercles on the lower first molar during closing the jaw. Now we need to make it a little bigger, and as you can see, here is our first permanent molar, upper jaw, lower jaw, and there is the ratio between these molars. It is called class 1. It is normal ratio between these molars. And there is a ratio between canines, the upper jaw and on the lower jaw. Now we will talk about this classification, but nowadays, if the patient, for example, they have on the one side normal canine position and in normal molar position, we make greater more attention on the position of the canines. So on nowadays, we need that the canines must be in class 1 in normal position. It is very important. Not as important as the position of the molars. So it is the class 1 position. It is the correct closing of the first permanent molars and the presence of maxillofacial anomalies in the front part of the tooth rows. So you can see that this pathology, this patient have a constricted upper jaw, but it have crowding teeth on the upper jaw, which we don't even see the lateral incisors on the right side, the crowding on the lower jaw, the maxillary constriction, but we told that this is pathology. It is the class 1 pathology because the ratio of the canines and the molars, it is normal. So this is the class 1 pathology. Class 2, violation of the closing of the lateral teeth due to the more distal contact of the first permanent molars of the lower jaw. So as we could see on this patient, it is a class 2 pathology. A class 2 pathology have two division 1 and division 2. So there is a difference between the position of the incisors. If the patient with class 2 division 1 and has a protrusion of the incisors of the upper jaw, so their incisors, they are protruded forward. If the class 2 division 2 or second division, the patient have a retrusion of the incisors of the upper jaw. So as we could see on this patient, we could talk that they have the pathology of the class 2 division 1. Why? Because the frontal teeth incisors, they are protruded. So this is the division 1. Why the class 2 pathology? Because the position of the first permanent molars and the permanent canines. So we see that the molar and the canine, they are forward. They then need to be in normal position. So we could see that the dental, this patient have a class 2 pathology. So when we talk about the pathology of the dentition, we need to say the skeletal pathology and the dental pathology. So, for example, the patient could have a skeletal 1 class, but the dental it could have a 2 class. So when we talk about the pathology, we do not need only to use these diagnostic models. We also need to make the cephalometric analysis about which we would talk further. So understand, this is the class 2 division 1 pathology. You could see this patient. There is a space between the frontal upper teeth and frontal lower teeth. The class 3 pathology. The class 3, the lower jaw is more mesial to the upper jaw. Includes cases when all teeth on the lower jaw at the moment of closure are more mesial. We need to make it bigger. So there are two patients with class 3 pathology. The first patient here, it has a class 3 dental. This patient have a class 3 pathology. Why? Because the first permanent molar and permanent canines, they are located on the upper jaw, they are located distally, then they need to be normal. So we could say that the dental classification in this patient have a class 3 pathology. And we will have another patient. When we see these diagnostic models, we could also say that she or he have a dental class 3 pathology. But upper patient have a functional pathology. More likely than the lower patient. It is a very simple method to diagnostic. In the class 3 patient, either they have a functional disorder or skeletal disorder. We ask them to make the incisor to incisor. Incisor to incisor, but if the patient could make this, as you could see that he could retrude the lower jaw distally and make an incisor on the incisor, we could say that in most percents this patient have a functional pathology, and we could treat them successfully, and there is a minimal risk of relapse. If the patient couldn't make the incisor to the incisor, couldn't retrude the mandible to this position, this patient have a skeletal pathology, so it is very difficult to treat them. If you talk about the orthodontic treatment, maybe they need to make even the orthognathic operation because they have a skeletal class 3 pathology. So there is a class 3 functional pathology and class 3 skeletal pathology. Okay. It was the classification of the Dr. Engel, which we use nowadays, but we talk that there is a dental classification. If we talk about the skeletal classification, we use the cephalogram or cephalometric analysis. There are two types, lateral cephalogram and frontal cephalogram. We use, if the patient have a crossbite, we use the frontal cephalogram and the lateral cephalogram. If the patient don't have a medial shift, we use only the lateral cephalogram. But all our patients need to make these lateral cephalograms. So here you could see the lateral cephalogram. There are a wide variety of methods to decipher or spell out these cephalograms. Now we talk about the method. For example, dose analysis. So here is the Dr. Dose, and here is his examination. Before we talk about his examination to determine the skeletal pathology of our patient, we need to know these dots. So there are dots on which we will make on this cephalogram. There is a dot nasion point. Nasion is a seam between the frontal and basal bone. So if we see there is a nasal bone, there is a frontal bone, and here we make our dot. It is called nasion point. literature. And the point center of cell turcica. The center of cell turcica is located when examining the profile image of the fossa. So it's on this fossa, and in the center, it is the point of center of cell turcica. Orbital point. Orbital is the lowest point of the left intraorbital margin. We see the orbital, and the lowest point, it is the dot orbital point. Porion point. Porion is the highest point on the upper surface of the soft tissues of the external auditory canal. So here is the auditory canal, and it is external point. We make it the Porion point. Pogonial point. Pogonial is the most anterior point of the lower jaw along the midline. So this is the lower jaw, the most frontal point, it is the pogonial point. Point R, or it is also called the dot subspinalia. Point R is the deepest point on the curved bony contour between the anterior nasal spine, here is the anterior nasal spine, and the procyon. Anterior nasal spine, procyon, the deepest contour is the dot point A. Point B between the infradentale and the pogonium. And the gnation. Gnation is a point on the chin that is determined by bisecting the angle formed by the facial plane, and the mandibular plane. Here we could see the dot gnation. And gonion point. The gonion point is a point formed as the intersection of the tangent to the back part of the branch of the lower jaw and its base. So is the dot gonion. In your practice, on the first view, you could think that it's very difficult to determine these points. And for these Domes analysis or Gibbs analysis or Cherabak angles analysis, Tweeds analysis, there are different types of these analysis. It's not too difficult to make this analysis if you make this every day. So if you every day work with patient, make this analysis, it could take all 10 minutes. If you will work every day 10 minutes, and there is not difficult to determine these joints and make, for example, Jones analysis. So the Jones analysis, it have two big parts. The first part is the skeletal pattern in normal lateralis, skeletal pattern. So we understand that the patient have a skeletal pattern and the dental pattern. Dental pattern we could see on our diagnostic models as we talked previous, and the skeletal pattern we could see only on the cephalometric analysis. So the skeletal pattern, it is a facial angle, angle of convexity, a B-plane angle, mandibular plane angle, and Y-axis angle, and relationship of the denture to skeletal pattern, count of occlusal plane, axial inclination of upper and lower incisors, axial inclination of mandibular incisors to mandibular plane, axial inclination of the lower incisors of the occlusal plane, and protrusion of maxillary incisors. So the first is the facial angle. Is an internal. It is important that it is internal, not the external, because the young doctors, when they become to work with patients, they make a mistake. The facial angle, it is the inner angle. Is an internal angle formed by the intersection of the Frankfurt horizontal plane, so the FH plane, and the IMPOC line. So the intersection and the internal angle expresses the degree of recession or protrusion of the chin. So if we need to determine if the chin of our patient is protruded or have a recession, we could make this analysis, the facial angle plane. The average value of this angle, it is 87.8 plus minus 3.57. These are average value. If our patient have a 82 or meaning or less, we could say that this patient have a class 2 malocclusion, not dental. skeletal. Now we're talking about the skeletal pathology. So the dental, our patient could have, for example, a class 1 occlusion without crowding, without spaces. But if we make this volumetric analysis, we understand that the skeletal, our patient has a class 2 pathology. If this angle in our patient would be 95 or more, we could see that this patient have a chin protrusion. And as we understand, previously the chin protrusion with the protrusion of the lower jaw have the patient with class 3 pathology. So I don't write this because the don't write, but if the angle is 95 or more, it means that the patient have a class 3 pathology. But the Tom's wrote that this patient have only the chin protrusion. He didn't wrote that the class 3 malocclusion. So this is the facial angle, angle of convexity. That is the second measurement, expresses the protrusion of the maxillary parts of the face in relation to the II profile. This angle is formed by the intersection of the line in A, between dot A and A. We made this long line, and A poke. Make an A poke. And if the in A and A poke intersects right side from the line and poke, we make plus. For example, it would be a plus 10, plus 1, plus 2, it will be a plus. If the intersection between in A and A poke is on the left side from the line and poke, we make a minus. It could be a minus 8.5, minus 2, minus 1. If the intersection in A lies on the in poke, in A poke lies on this line, we make a 0. The average value of the angle of convexity, it is 0. If the patient have a 8.5, it have a concave profile. So if there would be a patient which will you work, you could see the extraoral photos. You can make this angle of convexity tones analysis, and you'll see that this patient have the concave profile if the angle of convexity is minus 8.5 or more. If the patient has a plus 10, we said that this patient have a convexity profile or convex. So on this picture, if the plus 10, we can say that the maxilla is retruded and the mandible, that the maxilla is protruded and the mandible is retruded. If the angle of convexity plus 10. If the angle of convexity minus 8.5, we see that the mandibular is protruded and the maxillary is retruded. So we could see that in the first, the patient could have a class 2 pathology, skeletal. In second, the patient could have a class 3 skeletal pathology. So, for example, if we in facial angle could see a class 2 malocclusion. If we make an angle of convexity, we could see this protruded. So, if all these factors they confirm each other, only then we could say that this patient really have a skeletal class 2 pathology. So the AB plane angle, it is the third measure, allows you to assess the difficulty that the orthodontist may face when obtaining the correct incisal ratio. Not only the orthodontics, but the orthopedic also. When obtaining the correct incisal ratio and their satisfactory inclination. This is a measure of the ratio of the anterior limit of the apical bases of the jaw to each other and to facial plane. So the average value from minus 4.6 to plus minus 3.67. These are average values. If the epiplane is located in this right direction, relatively to the epoch, we say that these have a minus. If the epiplane has a location on the left side, relatively to the line epoch, we say that these have a plus. So it allows as a dose route, it allows you to assess the difficulty that the orthodontist may face. So if you see that the average, for example, average value is minus 4.6, you can see that it will be an easy treatment. If you can see it minus 10 or minus 11, you can say to the patient or the parents that there is a difficult treatment. Why? Because you know that the B-plane angle must be minus 4.6, but this patient have a minus 11 or minus 12, so there is a difficult treatment. Mandibular plane angle, it is very important. In other analysis, they call this the FMA, Frankfurt mandibular plane angle. Those call this mandibular plane angle. It is very important to know the mandibular plane angle. Measured between the Frankfurt horizontal plane, FH plane, and the mandibular plane, tangential to the lower edge of the lower jaw. Average value due to the domes must be 21.9 or plus minus 3.24 is the average value. If the patient have a 17 or lower, we could say that this patient, if we will work in clinical, not in the theoretic orthodontic or orthopedic, if we talk about really clinic practice, we say that this patient have a low angle. Why? Because the mandibular plane angle or the FMA, I will write you FMA, is 17 or lower, that this patient have a low angle. If, for example, mandibular plane angle or FMA is 28 or higher, for example, than 32, 33, we say that this patient have a high angle. And it is very important. For example, if the patient have a low angle, we couldn't extract the premolars and molars during our orthodontic treatment. For example, if you talk about the orthopedic, we don't need to make this angle lower because the patient have a low angle. In normal, we need to increase this angle a bit, to make the low angle a bit higher. And if the patient have a high angle, for example, if we talk about the orthodontic treatment, we need to extract the premolars to make the mesial shift of the molars and to make this angle 28 during the extraction and the mesial movement of the molars. We make the 28 to 32 and we decrease this angle. And it is very good for the health of our TMJ, temporomandibular joint. Why? Because if the patient with a low angle, which, for example, don't have a problem with TMJ, we will make the 17, we will decrease. For example, 15 or 12, the patient will have a problem with TMJ. If the patient with a high angle, we make more higher, we will increase this angle from 28 to 30 or 32. The patient will also have a problem with TMJ. So there is very important to know the mandibular plane angle or FMA and to use it correctly during your practice. The y-axis is the line from the sella to the gnation, which is used to express the downward and forward growth of the mandible. We will use this analysis in growing patients if you need to understand where would be the mandible growth. It is It is not only the one method to establish the growth of the mandibular. You could also see the Kim's analysis, Cherabak and others, but don't use this, the y-axis, in the growing patients. For example, the average value of the y-axis, it is 58.4 plus minus 382. Minimum 53. It means the horizontal growth. The horizontal growth means that the FMA, about which we talked earlier, if the horizontal growth, FMA would be would decrease. For example, if we see a patient with the FMA 17 and we made the y-axis and we see that this value is lower than 53, we could say that this patient have a low angle and the tendency to the protrusion of the mandible. If the patient, for example, have a high angle of 28 and the average and the value of the y-axis is more than 66, we say that this patient have a high angle and the tendency of the vertical growth. So this FMA even could increase. And if we will treat our patient even incorrect, we could increase this angle much more and the patient will have a problem with GMG. Cant of occlusal plane. It is a straight line that runs between the top of the cusp of the first molar and the point between the carinate of the incisors. In cases where the incisors are pronounced, supra or infraocclusion premolars are used. This is the cant of occlusal plane. So, to measure the cant of the occlusal plane, we use the FH plane or fractal horizontal plane. And this line between the top of the cusp of the first molars and the point between the catenates of the incisors. Average value is 9.3 plus minus 3.83. Minimum is 1.5 in class 3 patient, and the plus 14, it is a class 2 steep occlusal plane. So here is begins the dental analysis. So as we see earlier, it is the number 6, so cant of occlusal plane. Before we talked about the skeletal pattern, normal lateralized. Now we begin to talk about the dental pattern, relationship of the denture to skeletal pattern. So in the first, it is the cant of occlusal plane. So if the cant of occlusal plane in our patient is normal, we need to support its value. If the patient have a class 3 or class 2 steep occlusal plane, we need to level this curve of Speer and rotate it to the normal value, if it is possible. Why? Because problem of the TMG and the risks of overlaps. If we, for example, if our patient have a degree of 14 and we didn't change it during our treatment, it is a higher risk of relapse. So we need to rotate this cant of occlusal plane clockwise. Counterclockwise. We need to make the counterclockwise rotation of the cant of the occlusal plane. And in the class 3, horizontal, we need to rotate it clockwise. The 7 is the axial inclination of upper and lower incisors, interincisor angle. It is very important to measure the interincisor angle. The interincisor angle expresses the angle between the incisors, or you could see in the literature this word or this term as procumbency. Procumbency, it is also as an interincisor angle, so they are similar. Lines are drawn through the axis of the incisors and the internal angle is measured. So it is important, the internal angle, this angle measured, not this. We measure internal angle. The average value of the procumbency must be 135.4 plus minus 5.76. So it is the average value. If the outpatient have 130 or less, we say that this patient have a protruding position. So we talk this the bimaxillary protrusion. If we will treat this patient, we need to think about the extraction of the premolars, first premolars or second premolars, because if the patient have a protruding position of the incisors, it also, if we would see a profile of this patient would have a protrusion of the lips, and if we need to make a good lateral view, a good facial view, a good circuit or contour of the patient, our patient after treatment, we need to make this angle less. We need space to make it. So we need to think about the extraction of the premolars. If the value of the axial inclination of upper and lower incisors on each incisal angle is 150, we talk that this patient have a retrograde position. So if the retrograde position, we could make a slight protrusion of these incisors. But we need, first of all, we need to talk about the contours of the fascia. As you can see on the cephalometric, we see not only on the dental analysis. We look also at the nasolabial angle. Here is the nasolabial angle and labiomental angle. Because the patient don't need only to have the good the good position of the teeth. The patient also want to have a good profile after treatment. So first of all, we see at the profile of the patient, and only then we are going to protrude or retrude the central incisors. Because if we retrude these incisors, then nasolabial angle and labiomental angle, they are made wider. So these lips will go backward. If we make a protrusion of these incisors, so the lips are also going protrusion, and this nasolabial angle makes acute and labiomental angle make acute. So we do not need only to correct the position of the teeth. We need to make a good facial harmony of our patient. So it was the interincisor angle. Axial inclination of the lower incisor to mandibular plane. It is also very important. In literature, you could see also as the IMPA, incisor mandibular plane angle, IMPA. It is also as the axial inclination of the lower incisor to mandibular plane. But those called it the axial inclination in the lower incisor to the mandibular plane. But in the literature, you can see the IMPA. It is the similar. So the inclination of lower incisors to mandibular plane. Since the average value it means must be 90. Then the labial tip is described as a positive number in excess of 90, and the lingual tip is described as negative. So you understand that the average value of the axial inclination of lower incisor to mandibular plane must be 91.4 plus minus 3.78. So it is the average value. But in nowadays, let's talk that the average value of this inclination or the impact must be 90. It's very good. For example, if our patient have a value of this impact 81.5, we said that the lower incisors, they are retruded. They have a retrusive position. If this value is 97, we talk that the incisors, they have a protruded position. It is very important in our practice. So as you remind, in the beginning of this lecture, we talked about fields. The bones, they have negative and positive fields. Now I remind you, the field in the area of the lower incisors, it has a negative field. A negative field means that when we make when we make a pressure on this area, the bone resorbed. There begins the processes of the resorption. So in this area, in the area of the lower central incisor, there is a negative. For example, if our patient, when we make this analysis of the IMPA, and we see that our patient have the inclination is 97, and we want to protrude this teeth more, for example, to 110. But we couldn't do this because this field is a negative field, and if we will push this teeth forward, there would be a resorption. So you could have a good Instagram photo, but after your treatment, there would be a relapse. So this teeth would have wanted to make their position before this result of treatment. It wouldn't be stable. It is unstable. So we don't can to protrude these teeth. It is very important when we treat our patients with the class 3 pathology. Now I'll show you. So class 3 pathology, as you understand, there is a functional class 3 pathology and there is a skeletal class 3 pathology. We remember that the patient with class 3 pathology, they couldn't make a constructive bite. They couldn't retrude their mandible to make a incisor-to-incisor position. And if we make this patient a cephalometric analysis, and after our analysis, we understand that lower incisors have the position, the IMPA angle is 82 or less, it is only the orthognathic treatment. We couldn't help this patient without orthognathic treatment. Why? Because the alveoli in the area of the incisors, they have this form, if we could see, yeah? There, from this side, there is a negative field, we understand this. There is our incisors position. For example, that is its position in normal. But if these teeth have the angle IMPA is 82, they have this position. For example, this is position in this patient. And when, for example, we want to retrude this incisors, but we couldn't make this. Because why? Because there is no bone in this area. If the IMPA angle is 82 or less, it is only orthognathic treatment. It is very important to know. So there is the IMPA angle. Axial inclination of lower incisors to the occlusal plane. The ratio of incisors to the functional plane or occlusal plane. It is used to interpret the incisor-mandibular plane angle, IMPA, as I talked to you, IMPA. So the average value of the axial inclination of lower incisors of occlusal plane is 104.5 plus minus 3.84. 48, I'm sorry. The minimum value is 93.5, maximum is 100. This extrapolation lower sizes we do not use a lot in our practice, but you need to know that there is the DOMS use this in his analysis. But in our practice, we use IMP, we use the procumbency, we use the Y-axis angle, the mandibular plane angle, but we don't use the extrapolation of lower incisors to the occlusal plane as much. We do not need. You need to understand that there are a lot of different types of cephalometric analysis. Domes analysis, Steiner analysis, Jarabak, Kim, Tweed analysis. There are a lot of analysis. But when we work in our practice, we take only these moments or aspects of analysis which we need. For example, if we need to understand the position of the teeth and of the jaws, we do not need to make the whole analysis from begin to the end. We need only some of them. For example, only the Y-axis angle, only the SNB, if we talk about the Tweed analysis, if we talk about the Kim, it is the PTI. So we do not need to make all the analysis. We make only these aspects in which we are interested in during the diagnostic of our patient. And the last in the DOMS analysis is the protrusion of maxillary incisors in the distance between the cardiac edge of the central incisor and the upper jaw to the apoc line, and is measured in millimeters. So we need to know this, but in clinical practice we do not use it. The average value is plus 2.5 millimeters. The minimum is 1 millimeter, maximum plus 5 millimeters. So here is the end of the first lecture. Now we will continue the second lecture.
Okay.
So the theme of the second lecture is the sequence of orthopaedic patients examination and examination analysis. To achieve predictable success in this technically exacting and demanding field, there must be meticulous attention to every detail, from the initial patient interview and diagnosis through the active treatment phases and to a planned schedule of follow-up care. Otherwise, the result is likely to be unsatisfactory and frustrating for both dentist and patient, resulting in disappointment and loss of confidence in each other. Problems encountered during or after treatment, they can often be traced to errors and omissions during history taking and initial examination. And an experienced clinical may plunge into the treatment phase before collecting sufficient diagnostic information and help predict likely pitfalls. Making the correct diagnosis is prerequisite for formulating an appropriate treatment plan. This requires that all pertinent information be obtained. A complete history includes a comprehensive assessment of the patient's general and dental health, individual needs, preferences, and personal circumstances. History. There is a screening questionnaire. The patient's history should include all pertinent information concerning the reasons for seeking treatment, along with any personal information, including relevant previous medical and dental experiences. The chief complaint should be recorded preferably in the patient's own words. A screening questionnaire is useful for history taken. It should be reviewed in the patient's presence to correct any mistakes and to clarify inconclusive entries. If the patient is mentally impaired or a minor, the guardian or responsible parent must be present. The chief complaint: the accuracy and significance of the patient's primary reasons for seeking treatment should be analyzed first. This may be just the obvious features, and careful examination often reveals problems and disease of which the patient is unaware. Nevertheless, the patient perceives the chief complaint as the major problem. Therefore, when a comprehensive treatment plan is proposed, special attention must be given to how the chief complaint can be resolved. The unexperienced clinical trying to prescribe an ideal treatment plan can lose sight of the patient's wishes. The patient may then become frustrated because the dentist apparently does not understand or does not want to understand the patient's point of view. The chief complaints usually belong to one of the following four categories: is the comfort, could be pain, sensitivity or swelling, function, difficulty in mastication or speech, social, bad taste or odor, appearance, fractured or unattractive teeth or restoration or uh, discoloration. So the next set is the comfort. If pain is present, its location, character, severity, and frequency should be noted as well as the first time it occurred. What factors precipitate, for example, hot, cold, or sweet things, and any changes in its character. It is often helpful to have the patient point at the area while the dentist pays close attention. If swelling is present, the location, size, consistency, and color are noted, as well as how long it has been felt and whether it is increasing or decreasing. Function. Difficulties in chewing may result from a local problem such as a fractured cusp or missing teeth. It may also indicate a more generalized malocclusion or dysfunction. The social aspects. A bad taste or smell often indicates compromised oral hygiene and periodontal disease. Often social pressures prompt the patient to seek care. Compromised appearance, it is a strong motivating factor for patients to seek advice as to whether improvement is possible. Such patients may have missing or crowded teeth, or tooth or restoration may be fractured. Their teeth may be unattractively shaped, malpositioned, or discolored, or there may be a developmental defect. The patient's name, address, phone number, sex, occupation, work schedule, marital, and financial status are noted. Much can be learned in a 5-minute casual conversation during the initial visit. In addition to establishing a rapport and developing a basis for the patient to trust the dentist, smell and seemingly unimportant personal details often have considerable influence in establishing a correct diagnosis, prognosis, and treatment plan. Medical history. An accurate and current general medical history should include any medication the patient is taking, as well as all relevant medical conditions. If necessary, the patient's physician or physicians can be contacted for clarification. The following classification may be helpful. So, the conditions affecting the treatment methods, any disorders that necessitate the use of antibiotic premedication, any use of steroids or anticoagulants, and any previous allergic responses to medication or dental materials. Once these are identified, treatment usually can be modified as part of the comprehensive treatment plan, although some factors may sorely limit available options. Conditions affecting the treatment plan: previous radiation therapy, hemorrhagic disorders, extremes of age, and terminal illness. This can be expected to modify the patient's response to dental treatment and may affect the prognosis. For instance, patients who have previously received radiation treatment in the area of a planned extraction, they require special measures. It could be a hyperbaric oxygen, for example, to prevent serious complications. Systemic conditions with oral manifestations, periodontitis may be modified by diabetes, menopause, pregnancy, or the use of the anticonvulsant drugs. In cases of gastroesophageal reflux disease, bulimia, or anorexia nervosa, teeth may be eroded by regurgitated stomach acid. Certain drugs may generate side effects that mimic temporomandibular disorders or reduce salivary flow. Possible risk factors to the dentist and auxiliary personnel for the patients who are suspected or confirmed carriers of hepatitis B, acquired immunodeficiency syndrome, or syphilis. Dental officers practice universal precautions to ensure appropriate infection control. This means that full infection control is practiced for every patient. No additional measures are needed when dentists treat known disease carriers. Dental history. Clinicians should be cautious when commenting before a thorough examination is completed. With adequate experience, a clinician can often assess preliminary treatment needs during their initial appointment. Fairly assessing the quality of a previously rendered treatment can be difficult because the circumstances under which the treatment was rendered are seldom known. When such an assessment is requested for legal proceedings, the patient should be referred to a specialist familiar with the usual and customary standard of care. About periodontal history, the patient's oral hygiene is assessed and current plaque control measures are discussed, as are previously received oral hygiene instructions. The frequency of any previous debridement should be recorded, and the days and nature of any previous periodontal surgery, they also should be noted. Restorative history. The patient's restorative history may include only simple composite resin or dental amalgam fillings, or it may involve crowns and extensive fixed dental prostheses. The age of existing restorations can help establish the prognosis and probably longevity of any future fixed prostheses. Endodontic history. Patients often forget which teeth have been endodontically treated. This can be readily identified with radiographs examination. The findings should be received periodically so that periapical health can be monitored and any recurring lesions promptly detected. So as you can see on this picture, there is a small radiographic examination, but it is better to use a panoramic view. And if the two is endodontic treatment with it is called a contrast X-ray material. So if this teeth is endodontic treatment with X-ray contrast material, so you could see this picture. And if this teeth have a is the apical abscess. So this teeth, it's needed to be retreatment endodontically, you understand. Defective endodontics has led to recurrence of a periapical lesion. As you can see, retreatment is required in this case. So the oral surgical history. Information about missing teeth and any complication that may have occurred during tooth removal is obtained. Special evaluation and data collection procedures are necessary for patients who require prosthodontic care after orthodontic surgery. Before any treatment is undertaken, the prosthodontic component of the proposed treatment should be fully coordinated with the surgical component. Radiographic history. Previous radiographs may prove helpful in judging the progress of dental disease. They should be obtained if possible because it is generally better to avoid exposing the patient to unnecessary ionizing radiation. The dental practices usually forward radiographs or acceptable duplicates promptly on request. In most instances, however, accurate diagnostic radiographic series is essential and should be obtained as part of the examination. Temporomandibular TMG dysfunction history. A history of pain or clicking in the TMGs or neuromuscular symptoms such as tenderness to palpation may be caused by TMG dysfunction. And nowadays, in our patients in Ukraine, there are a lot of patients. There's a huge percent that have that problem with the TMG. They have the TMG dysfunction. There are two big categories for. As a wider category, these patients with ideal dentition or class 1 pathology, dental and skeletal, but they have a problem with the TMG dysfunction. And there are also persons of patients after orthodontic treatment which have the problem with the TMG dysfunction, because this treatment with the stretch wire technology without the disocclusion in the distal area, in mostly cases it leads to the TMG dysfunction, and they need the gnatology treatment, so they need to wear the topoprogrammator, the splint therapy, and after that an orthodontic treatment or total prosthetics. So the TMG is very important in our profession, especially as before fixed prosthodontic treatment begins. As you remember, it is very important to know the FMA frontomandibular angle, not to decrease or increase the height of the patient if it's not indicated. A screening questionnaire efficiently identifies these problems. The patient should be questioned regarding any previous treatment for joint dysfunction, occlusal devices, medications, biofeedback, or physical therapy exercises. Okay, and now facial proportions. This photograph is from the orthodontic book. So here you can see facial proportions and asymmetry in the frontal plane. So when the patient comes to you the first time, you need to make these photographs, frontal view and the lateral view. And in the frontal view, you could make these lines to show the patient if they have asymmetry, or maybe they wouldn't have this asymmetry. But in most cases, we are in these or that degrees, we are asymmetrically. An ideally proportional face can be divided into central, medial, and lateral equal fifths. So there, in this view, there are these fifths. So here we could see it is the central, medial, right, medial, left, and lateral left and lateral right. So there are 5 parts. The separation of the eyes and the width of the eyes, which should be equal, determine the central and medial fifth. So we could see that the corner, the medial corner of the eyes, they are on the border between the medial side and between the central side and the medial side. So here are the medial corners of the eyes. And the lateral corners of the eyes, they are on the border between the medial side and the lateral sides. So this in normal, but we understand that in each nationality, they have the differences. So we're going to see, for example, that the person from another nationality, they have problems if, for example, the corners they didn't locate in these corners. as it must be right, in each country there must be special researches or study about this problem, and there must be the average value for each nationality. So a lot of nationality we couldn't make the diagnostic only on one model. The nose and the chin should be centered within the central fifth, with the width of the nose the same as or slightly wider than the central fifth. Slightly wider in each nationality, they have differences. But if we talk about the Caucasians, this is the Caucasians diagnostic. So the nose slightly wider than the central fifth. The interpupillar distance, it is called also the dashed line, should equal the width of the mouth. So, for example, if your patient it has a facial asymmetry, and you talk them that okay, I could make you a good dentition with a good, for example, lateral profile with orthodontic or prosthesis. But for example, if you want to make a better facial aesthetic, you need to make aesthetic surgery, for example, to make the corners of the eyes, to make the corners of the mouth, to make this distance between the nose and the upper labial wider. So if the patient wants, if they don't want, so we only could recommend, and only then the patient makes its solution. But when you make these, the patient understands that you have a really high qualification, and then the patients will trust you as a good specialist. Composite photographs are the best way to illustrate normal facial asymmetry. For this boy, whose mild asymmetry really would be noticed and is not a problem, the true photograph is in the center. So here is the true photograph of this boy, and from the left side, on the patient right, is a composite of the two right sides. So here are the two right sides, and here is the patient with the two left sides. As if, for example, if you couldn't see this central photograph, we could say that there are two people, so they are not similar. So here is the difference between the left and the right side. So as you understand, it's wider than them. Why? Because this patient, this boy, it has a facial asymmetry. This dramatically illustrates the difference in the two sides of normal face, in which mild asymmetry is the rule rather than the exception. Usually the right side of the face is a little larger than the left, rather than the reverse as in this individual. In evaluating facial proportional relationships while looking at digital images on the computer screen, it can be helpful to put a box around the structures to be related. As in picture A, where the lip commissure height is being related to the central philtrum height, or as in B, where the width of the nose is being related to the interocular width. For this girl, both relationships are normal. For example, if this lip commissure height it is too short, we could recommend patient to make a operation, aesthetic operation, to make this lip commissure height bigger, to improve the facial profile of our patient. Vertical facial proportions in the frontal and lateral views. Best evaluated in the context of the facial thirds. So here is the first third, the second third, and the third third. which the Renaissance artists noted were equal in height in well-proportioned faces. In modern Caucasians, the lower facial third often is slightly longer, so this lower third is slightly longer than the central third. The lower third also includes thirds. The mouth should be 1/3 of the way between the base of the nose and the chin. So this is commissure height. It must be 1/3 of this lower height. When we work with our patients, if we talk about the orthodontic treatment, it is very important to make these photographs before treatment and every year. If we work with growing patient, if we work with adult patient, we also need to make these photographs before treatment and after treatment. For example, we talk today about the class 3 pathology. When the mandible is located forward due to the maxillary. For example, if the patient have skeletal class 3 pathology, this patient comes to us and we begin to work. It is important. If we work with a skeletal class 3 pathology, we talk to parents that we will make all best what we could do. For example, the therapy, it is the maxillary expansion and the face mask therapy. So we expansion the maxillary and move it forward. And the lower jaw, we moved backward. So there is the treatment. It is called the orthopedic treatment of the class 3. It takes from 6 to 8 months. After that, we will see if we will have, for example, a relapse after 1 year or 1.5 years. It is everything that we did. We do not begin to treat this patient with another techniques. For example, buccal appliance, now Frankel appliance, and different ways to move the upper jaw forward and lower jaw backward. Why? Because if it is a skeletal pathology, the mandible will grow on the latest studies. The mandible grows to 21 years. For example, you treat this patient first time, you have a relapse. Okay, you said, I'll give you a Frankel appliance. This poor child wear this Frankel appliance for 1 or 1.5 years. Then after a year, it have a relapse. You say, okay, we'll use, for example, a chin cup. You have a relapse in the third time. Okay, and at the age of 21 years, this patient who have a class 3 pathology. But what did you made? The lower third of this patient and increase a lot. So for example, if we treated this patient first time, we see a relapse, we make a cephalometric analysis, and we understand that it have a really skeletal pathology. At the age of 21, this patient would have a class 3 dental pathology, but his facial profile would be much better if we would treat this patient the whole life, and in the end, it would have a class 3 dental pathology, and the lower third, it would be increased much more. So it is very important. If you would treat orthodontically your patient with class 3 skeletal pathologies, always talk to your to child's parents that it is a class 3 pathology. We could make all best of us, but we will see if it will be a relapse to 21 years, we'll make nothing else. Why? Because we don't want to spoil the facial profile of this child. Because if we would spoil the facial profile of this poor child, he needed to make the orthodontic operation to lower this lower third of the facial profile. This is why it is very important to make these photographs before treatment and during treatment of your patient. So you need to see the result. You need to see the dynamic of your treatment. and to understand, could you make a better profile or you worse it? The usual case of excessive display of maxillary gingiva is a lone phase due to excessive downward growth of the maxilla. Downward growth of the maxilla. If we see a patient with a gum smile, as you could see here, it is called a gum smile. Gum smile. If the patient have a gum smile in most percent, the maxillary have a rotation. If you see, it's a clockwise rotation. So it's abnormal growth of the maxilla. To treat these patients, we use the special orthopedic treatment. We use a maxillator at the age of the 11. From 11, if we talk about girls, the peak of growth girls become at the age of 11. It is a moment when in the blood vessel there is a lot of the growth hormones. If we talk about boys, it is the age of the 12 years. It is the period when in the blood vessels it is a lot of the growth hormones, and we could use it. We could make orthopedic treatment of our patients. We could change the position of the maxillary jaw, for example. If these poor girls, they have a gum smile, we could give them a maxillator with a cap. We use a maxillator and they wear a cap from 5 p.m. to 8 a.m. each day. It is the moment when it is the maximum concentration of these hormones in the blood vessels. And only in this way we could change the position of the maxilla. So we could intrude this central segment and extrude the distal segment. And after 1 or 1.5 years of the treatment with a maxillator and this cup, facial cup, we could treat this gum smile in our patients. This should not be confused with display of gingiva in childhood, because the gingival gestation that accompanies eruption is incomplete, or with gingival display due to a combination of incomplete eruption and short upper lip. Yeah, there could be even a short upper lip. We make a examination, radiographic examination, and we see if it is a short lip or about the counter-occlusal plane, about the palatal plane angle, if it is rotated, if it is normal, we understand that the maxillary is in normal position. We do not need to make the orthopedic treatment, maxillator and cup. For example, we maybe need to make a upper lip bigger. Maybe the teeth are extruded. We need to intrude the teeth. We do not need to change the position of the maxillary. So it is very important to make the right diagnostic of our patients. On the picture C, note for the patients in the A and C, the lower third of the face, it is long. Here we could see this third, they are long. Whereas for the patient in B, the lower third is about the same length as the middle. So, for example, we do not make a cephalometric analysis, but we see these facials. If the lower third in the patient A and C, it is long, we could say that the FMA, franciomandibular or mandibular plane angle, it is high, that the lower jaw grows downward. Why? Because it has a long lower third. If the patient has a short lower third, we could see that maybe it would have a low angle. The FMR, frontomandibular plane angle, on the mandibular plane angle, it is lower. So the lower jaw, the mandible, it grows forward. It have a forward growth rotation. But to confirm what we say, we need to make a cephalometric analysis. Only after cephalometric analysis, we could say exactly if the patient have a high angle or a low angle, only after cephalometric analysis. Here you can see the profiles in the lateral view of our patient. Convex profile, straight profile, concave profile. If we see our patient, for example, the convex profile, or it's also, if it is very expressed, we say that it have a broad profile. These patients, if we see them, they could have a class 2 malocclusion. So the maxilla is protruded and the lower jaw is retruded backward. If we see a patient with a concave profile, we say that the lower jaw is protruded, upper maxillary retruded, more likely this patient have a class 3 pathology. So accentuated profile convexity or concavity results from a disproportion in the size of the jaws, but does not by itself indicate which jaw is at fault. A convex facial profile indicates a class 2 jaw relationship, which can result from either maxilla that projects too far forward or a mandible too far back. A straight or slightly convex profile is normal and usually reflects the normal jaw relationship, usually. Not always, but usually. A concave profile indicates a class 3 jaw relationship, which can result from the maxilla that is too far back or a mandibular that protrudes forward. Or why I say usual? Because there could be a patient with a straight profile. It is a good straight profile, but when this facial smile, we see, for example, a class 2 pathology. But it is compensated. For example, the lower lip has a big size, the upper lip small size, but the patient have a good straight profile, but dentition to the dental classification, it has a class 2 pathology. And we understand that if we will treat this patient orthodontically, dentition to the class 1, we could spoil his profile. So maybe this patient need to have an orthodontic I'm sorry, not the orthodontic, orthodontic surgery. So why? Because not to spoil the profile of our patient. Okay. 8 components of balanced smile. We do not need to have enough time. Okay, on our next lecture, we'll talk about the 8 components of a balanced smile. It is very interesting and you need to know this as a clinicians. It's not theoretically, it's those what we use in our practice. So thank you for your attention and see you again on our 3rd lecture.